Good morning, good afternoon, good evening. Welcome everyone to the second phase of HSR 2026 Global Symposium of Health Systems Research. And we hope you have been enjoying the many sessions. We are privileged to host this session titled Research Innovations and Interventions in Migrant and Refugee Communities. I, Preeti John, Dean, Chitkara School of Health Sciences and co-founder of Women in Global Health India, as well as Megha Girda, Monitoring and Evaluation Lead, Latika Roy Foundation, are jointly chairing this session. As we start, let us take a moment to remember the migrants and refugees around the world on whom the research and discussion today is based. I would also like to encourage all of you to enter any question that you may have in the live question and answer box. We will be taking them after the presentation. Please also use the discussion forum as a chat function. We will also be using poll questions during this session. Let's just start by testing our poll, and we request everyone to participate. The first question of the poll. Okay, responses are coming in, so just another few seconds. All right, thank you. So we do realize that migrant and refugee populations form a critical part of the vulnerable groups. Addressing their issues is a priority to achieving 11 of the 17 Sustainable Development Goals. And today, in this session, we have an amazing set of researchers who have researched and brought out new evidence on this very topic. It's my privilege to introduce our first speaker. Gautham Anand is a PhD candidate at the School of Public Policy, Oregon State University, USA. In his dissertation research, he examines the specific policy instruments within a large public health program in India to evaluate their effectiveness. Prior to joining the PhD program, he has worked for more than 5 years in India with social sector advisory of 2 international consulting organizations, PricewaterhouseCoopers and Mott MacDonald. His work involved program management and impact assessment of government programs with specific focus on health, education, and skill development. Let us listen to Gautham on the topic of his presentation, Overcoming Distance by Outreach, Role of Community Health Workers in Bihar, India.
Hi everyone, my name is Gautham and I am a third year PhD student at School of Public Policy, Oregon State University in the US. And today I'll be presenting my paper titled Overcoming Distance by Outreach, Challenges Faced by Community Health Workers in Bihar, India. So we are well aware that improving maternal and child health is one of the Sustainable Development Goals. and India being the second most populous country with the largest number of people under poverty, plays a critical role in this global campaign. The current neonatal and maternal mortality rates in India are twice the SDG targets for 2030. It is also well established that access to antenatal care is crucial for both reducing the neonatal and maternal mortality rates as well as improving birth and health outcomes for infants and mothers. However, in India, access to ANC still remains a big challenge. The National Family Health Survey 2015-16 tells us that only 21% women had full antenatal care. That means 4 ANC checkups, 100 days of iron and folic acid tablets, and 2 tetanus injections. And the situation is actually worse in rural areas and especially in poorer states like Bihar, which is the second most populous state in the country. So in rural Bihar, only 13% women had 4 antenatal care visits, just 3% of them had full ANC, and 44% of them did not even go for 1 ANC checkup. And been the this has been the situation despite National Rural Health Mission being implemented since 2005-6 in Bihar. And we know that the NRHM introduced a community health worker for every 1,000 population, and it also mandated registration of all pregnancies under the NRHM. Uh, so the pregnancy registration was meant to be as a service guarantee so that a targeted outreach can be done to ensure that every pregnant woman gets full antenatal care. However, it was weakly enforced, and 30% women in the NFHS 4 survey reported to not to be registered between 2010 and 2015. So taking advantage of the data from the National Family Health Survey 4, I look at the question that if pregnancy registration is associated with higher uptake of ANC, and I find that pregnancy registration is significantly and positively associated with both the probability of pregnant women getting at least 1 ANC visit and number of total ANC visits. However, when we exclude women with 0 visits, means once the ANC is initiated, pregnancy registration does not seem to be making a difference in the number of total ANC visits. I also see that pregnancy registration is not significantly associated with the probability of a woman getting full antenatal care. And we know that only 3% of women in rural Bihar had access to full ANC, so it is quite uh, possible that pregnancy registration is not making that difference, meaning there is a gap in the targeted program outreach as it was desired under the program. So to understand what are the possible reasons for these like this low ANC uptake, and maybe what are the challenges in program outreach efforts by the ashas. So I conducted a qualitative research in Nawada district of Bihar, where I conducted around 30 interviews, in-depth interviews. 21 of them were with ashas, and I tried to discuss like what could explain this low ANC utilization, or what could explain why the program outreach is not effective. And I would discuss 3 major themes here that came up in these interviews very frequently. And the first one can be broadly mentioned as lack of economic development. And it is historically in Bihar, the economic development has not been that great, and it restricts both outreach effort and ANC uptake. So a major concern that most of the ashas reported is that poorer households, poorer families in their community, they migrate to western states of the country for 5-6 months every year looking for work. And that means that sometimes they leave while women were pregnant, and sometimes they come back and report to be in the last trimester of their pregnancy. In such cases, it is very difficult for ashas to ensure that they get full ANC, because they cannot mobilize them when they are not there. And they also cannot control, or they cannot influence their behavior when they are working somewhere else. Obviously, widespread poverty is also a reason here. 80% of the respondents in the NFHS 4 survey report to be poor. And even if a program offers free ANC services, women do not want to go for frequent checkups because it involves transportation cost, and as well as they also suffer wage loss. So there is an opportunity cost involved in utilizing ANC care. Also, Bihar historically is known for its very weak health infrastructure. The primary health centers and the sub-health centers are ill-equipped to provide quality care to large number of pregnant women. Asha's report that it is also very time-consuming. Sometimes when women go there for their checkups, they have to spend one whole day to just get ANC checkup done. It means that they get really demotivated to come there again for the next ANC checkup. Also, since the ANC care camp generally is organized at the primary health center and they are not like nearby, they are in some cases they are far away from the rural communities, and there is also a challenge in terms of arranging for transportation for women to reach the primary health centers. Ashas also report that their work is severely undervalued. They do not get the institutional support that they should get. They are paid very low remuneration in form of incentives, and that also comes very delayed after a lot of bureaucratic hassles. So these factors kind of pose as a barrier in terms of their outreach effort in mobilizing women to ensure that they get full ANC care. Uh, like a lot of literature has pointed this out, sociocultural challenges still persist. Uh, a lot of women do not want to report their pregnancy after, like, before the first trimester is over. So ashas have to build rapport with the community, and once they build it, this problem could still be overcome. So in terms of future research, I would like to expand my qualitative work to understand the implications of seasonal migration for low ANC utilization. I had planned to conduct qualitative interviews this summer, but it could not happen, obviously. So I hope to do it in the near future. Thank you very much. Any questions?
Thank you for your deep dive into this important topic. You brought out several issues of migrants using public health care. We're privileged to have Mr. Gautham live with us. So I just want to ask a question to get a bit more insight for our audience in his research. Yeah, all right. So, from your research, you really brought out the fact that people from the state of Bihar, they go as migrants to work in other states. And you brought out the very important indicator of the pregnancy registration being a vital aspect. So when they migrate to other states, how does the pregnancy registration still get maintained? What kind of evidence did you find about this?
Yeah, so pregnancy registration means that a pregnant woman is being identified by the health worker and their name is being recorded with the primary health center or the Anganwadi center, right? And then they are issued a mother and child protection card, which enlists all the care that they should receive during 9 months of pregnancy and even beyond that once the child is born. And for every care, when it becomes due, there is a due list that health workers have to make, and they have to mobilize women who are due for that care to come to the Anganwadi or the primary health center. So when these women, once they are registered, but they have to migrate for work to other states, what Asha has told me that they convince them to carry the mother and child protection card with them. And if they receive any health care there at the place of their work, they must get that service received recorded in that card, right? It does not matter if they receive that care at a private healthcare facility or a public healthcare facility there, so that when they come back, ashas have like full-fledged information in terms of what kind of care they have received there. So this is the ideal situation, right? But we know that most of these women who migrate for work with their families, the level of awareness and education is not that high. Sometimes they do not carry the card. Sometimes when they come back, although they mention that they have visited some healthcare facilities, but they are not recorded in the card. So these challenges remain there. Ashas say that it is very difficult for them to ensure that these women receive full antenatal care because there is so much information gap, and they're also not sure like if ashas in those areas come to them, talk to them or not, or if they actually, what kind of work condition is there, if their employers allow them to go to health facilities or not frequently. So there are a lot of questions which ashas do not have control over, and also they do not know exactly what happens at their place of work.
Okay, I'm just going to ask you another very quick question. You have found this variable of the registration in the pregnancy register to be extremely critical. What would be your recommendation in terms of taking this forward?
So what I found is that pregnancy registration is associated with higher ANC uptake, right? Even the descriptive statistics tell us that, and even when we control for other variables like education, income, distance, the pregnancy registration is still significant. But I also see that pregnancy registration does not lead to access to full antenatal care, which is very critical. So my understanding and my suggestion is to actually build on that outreach effort, like provide that institutional support and incentive to the ashas, to the health workers to do that active outreach, and also improve the overall health infrastructure in a way that women feel encouraged to frequently visit the health centers, right? So the like ashas do not feel supported in a big way because they're not remunerated well, they're not paid well. So there's a gap there, there's a gap in terms of infrastructure. So registration is important. It's critical that identification is happening and women are coming into the public health fold, but it is also important to meet the demand there, to build that capacity, to have the outreach and to have the proper infrastructure to meet the demand of healthcare that they need.
Thank you so much for sharing the research as well as your insights. We'll probably come to you towards the end. Thank you.
Thank you.
Over to you, Megha. Yeah.
Thank you so much, Gautam, and thank you, Preeti. Our next presenter is Heidi West. Heidi West is a PhD student in the Department of Health Policy and Management, Fielding School of Public Health at UCLA. She works at the intersection of migration, gender, and health, primarily in the global context, and explores links between international frameworks and health system responses to migration. Her current work includes projects in Myanmar, Bangladesh, and cross-country comparisons using binational data and the DHS surveys. Heidi's research is bolstered by over a decade of international program development and management experience, where she used evidence-based approaches to build capacity and improve collaboration for diverse institutions. With a bachelor's degree in political science from US Berkeley and a master's in ethics, peace, and global affairs from American University, Heidi takes an interdisciplinary and mixed methods approach to producing innovative and timely evidence to inform the design and implementation of policy interventions that improve health equity. So let us listen to Heidi West on the topic of her presentation. Are wives of migrants in rural Bangladesh really left behind? A nuanced analysis of how spousal migration affects women's healthcare utilization.
Hello, everyone. Thank you for attending this virtual presentation today. My name is Heidi West. I am a PhD student at UCLA's Department of Health Policy and Management. The title of my talk today is Migration, Gender, and Health. Are Wives of Migrants Really Left Behind? A nuanced analysis of how spousal migration affects women's healthcare utilization. A little bit of background and context. So Bangladesh is one of the highest migrant sending countries in the world. In 2017, over 1 million Bangladeshis migrated overseas just for work alone. And this is an extremely gendered process. 90% of those 1 million migrants were men. This is due also to specific bans on women's migration that weren't lifted until 2007. When looking at the effects of this gendered migration process on women who are left behind, within the literature, there really are mixed results. It obviously depends on the country and context of migration, the outcomes that you are looking at, and the individuals that you're measuring these outcomes within. But what we do see in terms of healthcare utilization is remittances coming back from migrants can improve healthcare decision-making and utilization. We see this in studies in India and Mexico. When it comes to health outcomes, Wu et al. Found some negative psychosocial impacts on left behind children in China. However, in Indonesia, it was found that having a child or someone from a younger generation in your family migrate actually had some positive effects, particularly for the elders who were left behind. When it comes to measures of women's autonomy and gender empowerment, with migration, we can see some increases in autonomy for women, perhaps their mobility, but at the same time, also subsequent increases in responsibility for women with a migrant spouse. And again, these are different across different domains. In this particular study, we really wanted to dive into some of the intersections of the impacts of migration, but really what does that have in terms of other family structure and gender equality when trying to look at this relationship on healthcare utilization and outcomes for women. And we center this study in some rural villages in Bangladesh. The data set that we use is the Matlab Health and Socioeconomic surveys. This is a panel survey that was conducted in 1996 and 2012 on a representative sample of 7% of all households in the area. Matlab is about 2 hours outside of Dhaka and is characterized by very high rates of outmigration. So this study is unique in that despite these high outmigration rates and the long period of time between the two panels, they were actually able to capture 92 to 94% of all surviving age sex cohorts. For this particular study, we are, again, looking just at women and only at currently married women between the ages of 15 and 45 years old. Our main measure of interest is the effect of spousal migration, and for the results that I'll be showing, we're only looking at women with an international migrant spouse. We did some sensitivity analysis to look at different types of migration, such as domestic migration, and really found that all of the results that we're seeing are happening at the international level, so we have subsetted our variable to focus in on that. So what are some results around healthcare utilization? Women were asked if they had been prevented from accessing needed healthcare within the last 3 years, and what were the reasons why if they were prevented from accessing the care they needed. We found that women with an international migrant spouse were half as likely to be prevented from accessing healthcare compared to other women. These results held across multivariate, bivariate, and propensity models. Left behind women face fewer barriers to care, particularly financial barriers, as you can see from the chart on the right side of this slide. The blue bar, financial barriers were by far the main barrier that was preventing women from accessing healthcare, and they were reduced to less than a third for women who had an international migrant spouse. However, we did see some very slight increases in barriers put up by the family. So women whose families prevented them from accessing care or wouldn't let them go alone and they had no one to go with them. We also see increases in other barriers to care, which is a catch-all for some of the smaller barriers around transportation, being too sick to attend, etc. When looking into the effects of migration on women's empowerment and also sort of the interaction effects that this can have with family status, we're looking here in this chart at a graphical representation of the coefficients for variables for having a migrant spouse. That's the blue bar. The relationship that the woman has to her household head, so whether or not her household head is a member of her natal or biological family, perhaps her father or her brother, an in-law, or an interaction between having a migrant spouse and living either with her biological family or an in-law. As you can see, the effects of having a migrant spouse are quite positive for economic empowerment and mobility. We see increases in the index, and this index is measured from 0 to 100, 100 being the most empowered. So we see an increase of about 8 and 14 for economic empowerment and mobility for the women who do have a migrant spouse. However, we see negative impacts on the measures of of empowerment for women who live with their in-laws, or their in-law is their household head. And when looking at the interaction models, I would highlight the purple and turquoise bars that you see on the left side. We see a full moderation of those migration-related effects. So even if they have a migrant spouse, which could potentially have some positive impacts on their mobility or economic empowerment, if that particular woman is living with her in-laws, then that has been fully moderated, and we see some real negative effects on her empowerment. So what does this mean across the board? It means that these relationships are incredibly complex. When looking at the relationship between migration and health, it's really important that we also look at what's going on in the family context, that we look at what's happening in terms of empowerment, as these measures can also impact women's health, impact their ability to access healthcare. And when spouses migrate overseas, it definitely has a significant impact on the family structure at home. Reflecting some prior work done in India by Desai and Banerjee, also by Chatterjee and Desai and Naila Kabir, we really find that it's important to center your analysis on women if you're interested in finding these important interactions between the social, economic, and health domains. Would like to just acknowledge our funding sources and say thank you for your attention today. I look forward to continuing this discussion. Thank you.
Thank you. Thank you so much, Heidi, for joining us today and for presenting such an impactful and insightful presentation. And we are delighted that you are with us today. And I'll just ask some questions to you based on your research. So in your presentation, you did mention that the healthcare utilization and women empowerment stories, those were the two themes, that emerged from your study. So would you like to provide audience insights on that?
Sure, thank you. And thank you to our hosts and fellow panelists. The two big themes that really have emerged from this study were the impact of migration on women's ability to utilize and access needed healthcare, as well as the empowerment. And since originally submitting this paper, we've actually split these results out into two separate papers because of just the nuance and the real depth that's happening in both of these domains. So we find that migration is really significantly associated with both women's ability to access needed care, but also different domains of their gender empowerment. When it comes to the three-way relationship between these things, it's even more complex, and the family structure seems to be lying at some of the center of that. So how is household headship determined? How is decision-making made within households? Within the empowerment domains, we also just want to highlight, you saw in the presentation, we had them separated out into different domains. And one of the key things that we're finding, and this builds on prior research done in the region by leaders such as Sami Mahmood, is that when looking at a concept such as gender or women's empowerment, it's also important to separate that out and look across the different domains. So rather than just looking at it at empowerment as a single concept, thinking about decision-making as one domain of empowerment versus mobility versus, say, economic empowerment. And one of the reasons we find that very important to do within the context of migration is you see the perhaps the economic situation of the household shifting with remittances coming in from abroad, but who gets to make the decisions around use of those remittances occurs within an entirely different domain. So while economic empowerment may be happening, there may be more potential disposable income for use for things such as healthcare. If the woman in the household or the wife of the migrant is not in charge of that decision making around healthcare access, is not in charge of the decision making around where those funds are used, that economic empowerment might be moderated by that family structure. So I guess the answer to that is these two themes have very much emerged, and we're so nuanced and complex that we've actually separated them out. And I look forward to continuing to dive into the details of these interesting questions. Thank you.
Thank you so much. I would also want to ask, you must have employed several rich research methods to do your study. So would you like to share your thoughts on that?
Sure. So while in these short presentations, we don't have time to dive into all of the various methods, it has been important for us to understand that there often are very distinct differences between a family who might be more likely to have a migrant member of the family, whether that's a husband or a father or a son, a brother, and that we want to make sure that what we're not capturing is just perhaps some differences between these types of households to begin with. So the migration selection effect, if you will. We utilized propensity score methods to control for migrant selection, and as well as bringing in several controls from earlier versions of this panel survey. So controlling for household assets at earlier points in time, which are often what would determine whether or not someone would go abroad in the future. And our results were robust to all of these different tests and models. So we're finding there's a migration effect separate of just the selection into migration, perhaps from households who have additional assets or who have a history of family migration, et cetera, higher education levels, perhaps. Additionally, methodologically, similar to what the prior presenter was mentioning, it's often important to dive into sort of the whys and what's really kind of happening at the individual decision-making level within these households. And for that piece, we've actually added on some qualitative interviews that won't be covered in this particular aspect of this study, and data collection, of course, had to be halted with the onset of COVID-19 pandemic, but we have done some pilot interviews with women whose spouses were abroad and also those who have recently returned to really get into some more of the details of what's going on within specific family structures and different decision-making mechanisms.
Thank you. Thank you so much. We would love to read and hear more about your work. Thank you once again. So now we have time for the poll, and we would request everyone to participate. Our next question is, does your country capture data on migrants? The poll is timed for 10 seconds. So we would request everyone to participate. Okay, so 100% of the audience share that yes, the data is captured within the health information system. Thank you for participating. Over to you, Preeti.
Thank you. So moving on to our next presenter, I am privileged to introduce Catherine Cabahuma, who is a public health informatics professional and researcher with vast experience in private, government, and development partner organizational contexts at national and subnational levels. Based out of Uganda, she has worked with the Ugandan Ministry of Health, and she possesses combined experience and expertise in leading and conducting health information system strengthening programs, monitoring, evaluation, learning, and research efforts. Currently, she is with UNICEF Uganda. Let's learn from Catherine as she speaks about integration of UNHCR Refugee Health Information System into the National Health Information Management System for Uganda.
Yes. Hello, everyone. My name is Catherine Cabahuma. I'm a public health informatics professional and researcher from Uganda, East Africa. I'm strongly driven by the value of information, innovation, and health equity, and therefore I'm keen on improving health service delivery access, quality, and health outcomes. What I'm about to present is a piece of work that I supported while serving as a health informatics specialist at the Uganda Ministry of Health, together with colleagues from the district health offices, development partners, and implementing partners. This presentation is about the integration of the UNHCR Refugee Health Information System into the National Health Management Information System for Uganda. But first, before I go ahead with the presentation, I would like to provide you with a brief overview on refugees and asylum seekers in Uganda. As of June 2020, the total of refugees and asylum seekers in Uganda stand at 1.4 million, 25,040 people, with countries of origin for this population in order of highest to lowest, including South Sudan, Democratic Republic of Congo, Burundi, Somalia, Rwanda, and others. The total number of refugee settlements stands at 14 as of 2020 still. These statistics are a great elaboration of Uganda's true hospitality, and more importantly, as a country that cares a lot about the people, the rights of the human rights of the people beyond her borders. So I'll quickly run through, with this presentation, I'll quickly run through, give you a background and rationale behind a proposed model that countries can adopt to integrate two systems, mainly the national HMIS and, for example, the refugee health information system. I will just quickly go through the method, the results in terms of outputs that were achieved using this proposed model and the method. And lastly, I'll take you through I will just appreciate everybody who took part in this, intervention. So just to give you a little bit of background, as a country, Uganda has adopted the 2016 New York Declaration's Evolutionary Comprehensive Refugee Responsive Framework. And the Uganda Ministry of Health has increasingly recognized the importance of including refugees within strategic plans. And so still the government of Uganda, through the Ministry of Health, with support from development partners, has continued to provide support services to refugee hosting districts to successfully manage the refugee population in the settlement services, including food, nutrition, protection, healthcare, and water and sanitation. This has increased the need for timely and accurate information to facilitate planning, resource allocation, and decision-making in general. But then the health data management in refugee settings is faced with several gaps common, and these require harmonization For instance, in this case, they required harmonization of the UNHCR Refugee Health Information System with the Uganda HMIS. And so through a consultative stakeholder meeting held back in May 2018, which was aimed at reviewing the Uganda HMIS and the UNHCR Refugee HIS data management systems, it was held, and it was to identify ways to harmonize the two systems, but also achieve an integrated system for monitoring health service delivery in Uganda. The stakeholders that participated in this important convening were, among others, the Government of Uganda, Ministry of Health, District Health Teams, UNHCR Uganda representatives, UNICEF Uganda representatives, the United States government, particularly the US mission, and other civil society organizations operating in Uganda. So what came out of this very important convening was 4 clear outputs, which is the clear current plus desired refugee data flows, which particularly brought out or delineated the gaps and pain points, therefore making clear what was required as a remedy. For example, the then current refugee data flow highlighted that after data collection and compilation of this data at the facility level, this data was then entered into the UNHCR Refugee HIS, and therefore making it inaccessible to other stakeholders, like MOH and partners. Stemming from this then was a desired data flow that ensured refugee data is entered into the national HMIS or DHIS to system accessible to all stakeholders. Another clear output was the challenges that were brought out, including the parallel use of the two systems, which mainly brought about the variances or discrepancies in the data collected by the two systems, but also the lack of inclusiveness in capacity building plans, and of course, as mentioned earlier, inaccessibility of refugee-specific data for planning. With these challenges, stakeholders discussed and agreed upon key recommendations to remediate these challenges, including redesigning the national HMIS recording and reporting tools, including refugee indicators and elements, together with the corresponding electronic version of the HMIS built on the DHIS2, training health workers and ensuring adequate supply of HMIS tools, not leaving out the supportive supervision, including refugee facilities in refugee hosting districts. So to conclude this, what you see here is a proposed model that other countries, for example, Uganda is one of those countries that have successfully gotten consensus among the stakeholders as far as harmonizing national refugee stakeholder needs is concerned. So this is a framework that other countries who would like to go to that direction, to take the same direction, can use. It includes components such as the stages. If you see on the right-hand corner, the stages, activities, and outputs. So in brief, using this model, a country can go through these stages, including problem analysis and consensus building, integrating stakeholder information needs, and implementing key activities that then would lead this country to achieve an integrated information system fully implemented according to user needs. This presentation, I wouldn't be making this presentation without the support leadership from Ministry of Health Uganda, and particularly the Division of Health Information, the UNHCR, which is the UN agency for refugees in Uganda, UNICEF Uganda, the United States government, and other civil society organizations that majorly do the implementation work in the districts. Thank you.
Thank you so much, Catherine. I think the framework you have brought out is extremely important in today's context, where we want the data and information system to be synergistic So may I request you to be available and answer the question of, I'm sure from the time you have done this research and presented to us, what's the update right now of harmonization of these two information systems?
Yes, thank you, Preeti, for that question. Well, like I said like you watched in the presentation, this is work we did started in 2018, and now we are in 2020, and so by now we are in the implementation phase of this already harmonized system. It's our national routine health information system in Uganda, and it was harmonized, and now it's allowing for collection and generation of health and nutrition data that is disaggregated by national, which is a host, a person who comes from Uganda or Ugandan, refugee, and foreigners, sometimes also called migrants, depending on the perspective within which we are speaking. And this before this harmonization, this was not possible. We had data that that was not disaggregated in this way, and so it would be difficult for partners that are supporting Ugandan communities to tell if a client or if people or individuals reached either nationals or refugees. And so with this harmonization or integration of the two systems in terms of the data elements and indicators, this has been possible, and it came so handy even when it was when COVID broke out in the entire world, but also particularly in Uganda, because then we saw all of us rushing to the system and looking for, especially in refugee hosting districts, whereby yes, the country had been, a lockdown had been commissioned, but we're still seeing people moving in and out of the country. But because we have this system now, at least we can be able to tell among, for example, women who are accessing antenatal care services, which ones are refugees in the refugee hosting districts, for example, which ones are refugees, which ones are nationals. And you'll be surprised that you might find things that you don't expect. So that has really been good for everybody. People are able to access the system, the data for refugees and foreigners, and of course there are challenges, and these are challenges that we all anticipated when we're discussing and doing a sort of a risk-benefit analysis of what we're trying to do. If you harmonize these two systems, what challenges are going to come about? First is that one of knowledge of health workers. The knowledge health workers have in trying to use these tools or system to record and report data. So that's a challenge that started at the beginning of this year. We had it, but then of course, as the year went by, we've been seeing improvement, because we knew this was going to be a problem. Partners and Ministry of Health, of course, planned trainings and mentorships around that. And then also, of course, things like shortage of tools, the paper-based tools in facilities, resource mobilization, because of that whole community that the Division of Health Information built in terms of making efforts towards strengthening the health information system has really helped, because then the ministry is able to lead and coordinate different partners to see how they chip in to purchase tools for the health workers at the health facilities. So there's much going on with the system, but just in short, it's being implemented, and we are happy. People are smiling that at least they can access the data, the refugee data, and which was not possible before. Yeah, thank you.
Thank you so much, Catherine. I mean, you gave us an update, and you also brought out the different challenges. If you could just say 2 points as advice to others who want to adopt it for their district or province or state or country, what would be 2 key advice if they adopted this framework?
Okay, thanks, Preeti. Yes, one is about engaging stakeholders. This is a very, very, very vital step for just not even the routine health information system, but in general for health information systems. Engaging stakeholders is very key. These are partners These are health workers at the health facilities who actually use these systems, who are the end users. The planners, engaging them from the beginning is a very vital step, because then it helps smoothen the entire process of trying to strengthen or trying to make a more comprehensive and integrated system. It helps a lot with that, because then you won't be speaking a different language in the future, but then you will be just continuously building on with whatever you've discussed and built in the future. The other thing is about planning. You said two things, but planning to have capacity building continuously, at least every 2 years. And then having a technical team that is really dedicated to this kind of initiative. Because if you don't have a dedicated team, this is work, and that I'm talking about the harmonization, but also the much bigger initiative we were trying to accomplish was to revise the National Health Management Information System. So this work was part of that. So to do that, you really need a dedicated team of just not software developers for DHIS2, but also for business analysts, for people who are able to understand user needs, because then it helps to build a system that is more responsive to end user needs. Yeah.
Thank you so much, Catherine.
Yeah.
We will touch base at the end. Thank you.
All right.
Thank you so much, Preeti, and thank you, Catherine. We are delighted to welcome our next presenter, Dr. Shahabuddin. Dr. Shahabuddin, thank you so much for joining us today. Dr. Shahabuddin is working as a health specialist at the Implementation Research and Delivery Science Unit at UNICEF headquarters in New York, where he supports and coordinates implementation research initiatives around immunization and MNCH programs. Over the past 11 years, Dr. Shahab has worked as a researcher and a research utilization specialist for different organizations, including the Institute of Tropical Medicine, Antwerp, Brad James Migrant School of Public Health, FIGO, and FGI 360. Dr. Shahab is an emerging voice for global health from the cohort of 2016 Vancouver. Let us all hear from Dr. Shahabuddin on key challenges of conducting embedded implementation research in a humanitarian setting with the Rohingya refugee population in Cox's Bazar, Bangladesh.
Hi everyone, my name is Shahabuddin. I work as a health specialist at the Implementation Research and Delivery Science Unit at UNICEF headquarters in New York. I'm going to present a study entitled Embedded Implementation Research in Humanitarian Settings, Learnings from an Experience with Rohingya Emergency in Cox's Bazar, Bangladesh. Embedded implementation research promotes evidence-based decision-making and policies by involving researchers and decision-makers in the process of research, and also by focusing on research questions which are related to implementation. Embedded IR has been done in different contexts, but so far we know there are limited experience of conducting IR in humanitarian settings. To keep that in mind, we conducted a study which documented methodological and operational challenges in conducting IR in humanitarian settings, and also highlighted key lessons learned which could guide future IR initiative in such settings. In order to reach the objectives, we visited Rohingya refugee camps in Cox's Bazar and reviewed relevant documents. We visited several health centers, health posts within the camp to understand health service provision and different health service delivery mechanisms. Besides, we interviewed with stakeholders and representatives from UN organizations, several national and international organizations, also representative from the government. Besides, we interviewed with the members of the BRAC University research teams, because BRAC University have conducted an embedded implementation research in Cox's Bazar, and we spoke with the members of that team to understand their own experience and also the challenges that they have gone through. In terms of data analysis, we followed a thematic analysis approach. In terms of results, there are several characteristics which made the context in Cox's Bazar unique and complex: geographic location, high population density, and change in the severity of the emergency. There are more than 100 organizations are working in Cox's Bazar with broad range of activities. Respondents have mentioned about the lack of coordination among different actors, and there has been strong presence of UN organizations and international organizations which have been playing role in decision makings. Respondents have highlighted that there has been continuous changes in service delivery modalities and policies. Initially, given the severity of the crisis, different organizations really struggled to meet rapidly rising demand for basic services. But over the past 3 years, the demand has grown more acute over time. So when we talk to the members of the Bragg University research teams, so they have suggested that IR should adapt to address the ongoing implementation challenges, and it should be flexible with research questions and method that can be modified as needed. And they have also highlighted that it is critical that IR approaches and methods should enable quick results to fill the immediate knowledge gaps to make a decision. Respondents from Bragg University, they also highlighted that they had difficulties to access the camps and Rohingya research participants because most of the camps are built in hilly areas which are highly vulnerable to floods, landslides, and cyclone. And the time they did their own data collection was during the rainy season, and they had difficulties to access the community's health facilities and to find relevant respondents. So one of the suggestions that they have provided to collect data outside of the rainy season in order to save time, cost, and reduce health risk to the research team. Respondents also highlighted the barriers related to language and to access quality information. And also they have highlighted need of experienced research partners to conduct IR in emergency settings. They mentioned about challenges in identifying research assistants who speaks the Rohingya language, and also identifying research assistants with skills in conducting qualitative interviews and focus group discussions. Participants also highlighted the importance of collaborating researchers or institutions who are familiar with emergency context and particularly familiar with conducting embedded implementation research. 5 key lessons highlighted by the research participants. First of all, understand the context and analyze the role of relevant stakeholders to map potential implementation challenges and to understand the key decision maker in emergency context. Secondly, use simple descriptive methods which are more appropriate to answer real-time implementation challenges and questions rather than using complex experimental design. We should pay close attention on how to access the camps and how to access the research participants in any context, and also recruit researchers who speak the language are acceptable to the study population. And instead of working with external researchers, it's always recommended that work with local researchers with specific skill sets and who have prior experience in working in humanitarian context. That's all from my side. Thanks very much.
Thanks very much, Dr. Shahabuddin, for sharing with us challenges, the gaps, and also the potential of conducting implementation research in a humanitarian setting. Also, in your presentation, you did mention that the use of implementation research is still limited in a humanitarian setting. So, would you like to talk and elaborate more about embedded implementation research, and why is that you opted for that?
Thank you, Megha, for your question. So at UNICEF, we have been supporting implementation research over past several years in several countries, mainly in research support settings. So as I have mentioned in my presentation that this is the first time we have done IR in humanitarian settings, which we have done in Cox's Bazar among Rohingya communities. And the approach we used for implementation research, it starts with research questions, and questions are mainly developed by the implementers themselves. And then research is done under the leadership by the implementers or decision makers in collaboration with in-country researchers. So over past few years, we have seen the implications of implementation research in UNICEF supported programs in several countries. We have seen that it contributed to improve data and information management system. It's contributed to improve human resource systems. It contributed to improve supply chain management system for immunization and other programs. So thinking about the role of implementation research, we thought to kind of test whether it improves the situation in migrant populations for program implementation or not. That's why we have considered to kind of testing this approach in humanitarian context, and we selected Cox's Bazar for that. And yeah, and we have organized actually the research teams and the people who are part of the research itself. They have organized a dissemination workshop at the end where several key decision makers from the government, also from UN organization, they have participated, and the research teams were able to sensitize them about the implementation challenges that they have found in the context of Rohingya population. And after that, what I have heard that some of the organizations they have considered the research findings and developed new programs in the area of MNCH, also in the area of health system and also demand generation. Yeah.
Thank you. Thank you. You also mentioned that there's a strong presence of the Bangladesh government, the UN agencies, and many international organizations, but there's still a lack of coordination among different actors or organizations. So, what mechanisms, can be created for improved collaborations between them?
Thanks, Megha. This is a really good question. So we found that in some areas of service delivery and program implementation, there is still lack of coordination. And in the context of Cox's Bazar is unique, like more than 100 organizations are working together. Let me give an example in terms of coordinations related data and information system. So in Cox's Bazar, what we have found that most of the organizations, they have their own data collection system and own data collection mechanism. So it is not done really in a coordinated manner. So to solve these problems, what we have gathered that strong leadership and governance systems are really necessary with specific guideline, and also there should be strong monitoring and supervision system in place to ensure that those guidelines are ensured on the ground.
Thank you so much for sharing, and we really appreciate that you could join us today. I hand over to Preeti now.
So I would request all of you, all the speakers, you have brought out so many interesting insights, not only about the issue of migrants or refugees, but also the kind of impact it has on their families, the kind of impact it has on the health system, and the need to make structures, stakeholders, coordination mechanisms much stronger. So I'm just going to take a minute to ask you to reflect on we started out with saying that in this year, when the Agenda for Sustainable Development Goals came out, they recognized for the first time that migration was contributing to 11 of the 17 SDGs. So could you, each one of you, reflect and talk about how does your research contribute, your research evidence contribute to achieving these goals? And may I ask, Gautham, would you like to go first?
Yeah. One aspect is that it's really important to understand from families who migrate seasonally, right? Because migration is one thing and seasonal migration has a very different nature and implications for access to health services, because they go to a place for only 5-6 months of a year, and that is also not for sure that they will keep going to the same place every year, because they are these labor contractors and they can take you to different places different years, right? So it's really important to understand from the women themselves in terms of what kind of challenges they face, what kind of health care they require, and not only related to mother and child health services, but also overall health services that they require. And what facilities or what kind of services are available wherever they go. Is there a way to ensure that there is a proper record being kept by the health workers at both the places in terms of outgoing migrants and incoming migrants, even if they're seasonal in nature? So really important to think like in that direction in terms of how to best provide the services that they need, and how to fill that information gap that is there, both in terms of accessing and having the program outreach.
Thank you. Heidi, would you like to add your inputs?
Sure. Just sort of building on what Gautham had said, I think it's really important that we're getting the experiences of these families specifically in regard to how they're able to access health services, how health outcomes might be varying when you disaggregate by different types of migration. And one of the things that our study does is it really takes it beyond looking at the migrant themselves. So while that data is very important, we understand that migration is really a larger, more comprehensive process that involves much more than an individual who might be migrating, but the family who might be left behind as well. And so kind of understanding the interplay between sending and receiving countries, how policies in one country may be affecting the health and well-being of individuals in another country. When it comes to specific SDGs, I would say this work really touches on obviously SDG 3, good health and well-being, but really much more so probably SDG 5 and looking at gender equality and focusing really in on women. I think the call for sort of disaggregation of data in the SDGs, particularly as compared to the MDGs, which came prior, is really going to be critical in thinking of what groups should we be disaggregating by when we're looking at the different targets and indicators of these goals, and arguing that migration status is key, but also kind of looking at the whole family, not just individuals.
Catherine, would you like to add on to that?
Yes, thanks, Preeti, and everyone. The work or this paper, and rather the work reflected in it, of course, mostly touches SDG 3, that is to do with health, and then also somewhat to do with Zero Hunger SDG 1. But just to answer the question, I think it contributes mostly to the monitoring and evaluation aspects, and also planning. And of course, this comes from a place of where we were moving from as the world. We were moving from MDGs to SDGs, and one of the key issues were the inefficiencies in the whole pillar of monitoring and evaluation. And so through shifting from a national routine health information system that's got more generic info about the people living in Uganda, the health and nutrition services offered, the diseases of public health importance, to an information system with a more disaggregated data, I think, that looks at nationals, refugees, and foreigners and migrants, I think in a way helps to strengthen the monitoring aspects, because then we get more precision into who are we looking at, and then who is more deprived and why. So it helps us build that momentum, and that asking why and why and why, because of the information that is more disaggregated that's being provided. Yeah, thank you.
Thank you. And Dr. Shahabuddin?
Sure, Preeti. Briefly, I want to highlight the potential role of implementation research in achieving SDG targets related to migrant and refugee population. I believe that each country have programs and intervention related to indicators for migration and refugee populations and target as well. So when we see we are not able to achieve a target, so one of the reasons might be related to implementation challenges. And where there is implementation challenges or implementation research would play a role. As I mentioned, that it starts with the questions related to implementation challenges or implementation. And we have seen that the implications of IR in normal settings, in improving programs effectiveness around immunization and maternal child health programs. And we have also seen how embedded implementation research contributed to some extent in informing programs in Rohingya refugee context. We acknowledge that embedded IR is not done much in migrant Rohingya or migrant or refugee populations. And I think that area we need to invest more, and hopefully we'll be able to prove that that IR could potentially improve programs for migrant population and refugees.
Okay. I think all of you, through your research, you have kind of unpacked the so many layers of issues to really study and understand about migrants and refugees. And you've also used very innovative research methodology to kind of bring out all this evidence. So it's extremely important. All the good work that you are doing comes into action, into policy. So a very quick last question as we wind up this discussion. If each of you could state one research priority that you see for taking this whole agenda forward. And again, could I just start with Gautham, then Heidi, then Catherine, and Shahabuddin?
Yeah, so my research agenda going further is to talk to these women who go seasonally go for work and try to understand from them their health-related experiences, because I do not find a lot of literature which covers the health experience of seasonal migrants per se. Thank you.
Yeah, thank you. Just to kind of reiterate what I had mentioned in response to the prior question, I think the research should really be looking more holistically beyond just an experience of a migrant in a receiving state. So including looking at not just health, but occupation and housing, status and rights, and the intersections and relationships between sending and receiving states. and how these state level relationships are having an impact both on the migrants' experience and that of their families.
Catherine?
Yes, thanks, Preeti. Yes, in the spirit of health for all, and of course, including refugees and migrants in the different countries, I think strengthening country routine health information systems, and particularly zeroing down to the decision science and utilization of data in terms of how best this can be improved in countries, especially those that are struggling with those aspects, would be a priority for me. Yeah, moving forward. Thank you.
I would say we need better understanding about how implementation research could play a role to inform policies and programs for Rohingya, for migrant and refugee populations. We need implementation research across different regions, different contexts, and different areas of health systems, different health issues. And to do that, I think implementation research should be embedded in every programs focusing on the migrant and Rohingya refugee populations.
Thank you so much. Over to you, Megha.
Thank you, Preeti, and thank you, everyone. And I want to thank all the speakers for enriching this forum and sharing your valuable time and deep expertise with us. You know, it gave us many insights on innovations and interventions in migrant and refugee communities. And you all are doing phenomenal work and, you know, working on a shared concern, you know, which I believe will definitely, you know, lead to the achievement of the Sustainable Development Goals. And it was an honor, you know, to work with you and introduce you all. We really look forward to hear and read more about your work. A big thanks to all the delegates and all the attendees for, you know, joining us today. And we really appreciate that, you know, you took out your time and joined us today. Thank you so much.